Okay, in a previous video, I discussed about intubating a patient through an LMA using an Aintree. One of the things that to remind everybody, that was in the last video, but just as a reminder, when I use the Aintree, I personally cut it a little short so that you can see there's a little extra scope sticking out. And when you do cut the Aintree a little bit short, I personally also cut the same distance. If I usually cut this around 3 centimeters short, I also cut 3 centimeters off the endotracheal tube that I plan on sliding over the Aintree to put that in. That's just a quick reminder for everybody. Now what we're going to do is we're going to use a different technique, not using an Aintree, to intubate a patient through an LMA. The setting is, it's a difficult intubation, easy to ventilate. Your LMA is now in. This is a number 4 LMA for a garden variety patient. What I do with this in this setting is I take a number 6.0 uncuffed tube. The reason I use an uncuffed tube is the cuff can get in your way when you're trying to thread something in place. I don't like it and you don't need it. However, one of the things I do is very aggressively bury the adapter into the endotracheal tube, because how the various pieces of equipment allow you to get this done is with the LMA in place and you thread this tube through, you will see that the tube sticks out well below the cords. In this setting, the cords will be approximately where the double line is, or between the double line and the black tube, or the black part of the tube. As an aside, unless it's extreme duress, I never, ever use a disposable LMA for this process. I always use the non-disposable LMA. There is something about the plastic, there's something about the curve. Every time I use a disposable LMA, I regret it. I always use a non-disposable LMA for this approach. So now your setting is, you've got a non-disposable LMA in the patient, you've got your pediatric scope, you now thread your 6.0 uncuffed tube over the pediatric scope. It fits easily, slides easily. I personally use these pieces of equipment, a pediatric scope and a 6.0 tube for a garden variety adult. If you need to intubate a larger or smaller adult, the technique is exactly the same. It is just that the equipment is slightly different. So now you've got your 6.0 tube loaded onto your pediatric scope. You can now put your scope through your LMA, and when you get to this position, you can see there's your center grill. The pink thing at the top is the epiglottis, and there's your arytenoid cartilage. You go below the epiglottis, above the arytenoids, and there's the plug for the trachea, or for the dummy, and now you advance this in. Now you're looking at the carina. I personally ask somebody else to hold the scope for me because I like holding the LMA and advancing the tube in. Now the scope comes out. And this is why I like using this technique under certain circumstances, because right now I can ventilate the patient. If I've got bad lungs or some other reason why the patient gets hypoxic, you hook your circuit up to this technique, to this, and you put your hands around the mouth and the nose, and now you can ventilate your patient. And you can actually do this for a while, blow off CO2, increase your oxygen, it doesn't matter, you can ventilate this patient. The other reason to do this is, unlike the Aintree where you're actually working blind, you do know that the tip of this tube is in the trachea because you are getting CO2 back. So now you're at this setting, this is in. I personally now use the intubating stylet. All intubating stylets come with a little bend to the tip of the tube, tip of the stylet, sorry. I lube it up. I personally go through the trouble of just temporarily straightening this out. All you've got to do is just bend it straight, just a little bit, don't need to do a lot. Your stylet is lubed up. You mark your 25 centimeters at the tube, or on the stylet, and then you push your stylet until you have 25 centimeters at the gum line or the teeth. That is critical, because at 25 centimeters, you're still above the carina for most adults, but well below the vocal cords, which is important. Next thing you do is you deflate your LMA, And now this maneuver is kind of important. I personally hold the stylet here and pull the LMA and the tube out while holding the stylet still. I very aggressively hold on until everything comes out easily. Once you get to this point, you can reach into the mouth, grab the stylet, make sure you've got a firm grip on it, and very slowly pull your LMA and 602 combination out. Now you've got a stylet in the trachea. You get your endotracheal tube, and now the second part of this maneuver is very helpful. You'll notice that I'm very purposely threading the endotracheal tube over the stylet with the Murphy eye straight up. That angles this bevel such that it doesn't catch on the arytenoids. If you turn this around and I bend it a certain way, you can see there's a fair amount of space right where my fingertip is. That will catch the arytenoids. If you turn it around this way, that space doesn't exist because the curve is going like that. Deflate your cuff. Hold your stylet here so you don't advance it, and now you put your tube in. If you want to confirm, you take your scope and you can confirm that you're in, and lo and behold, there's the carina. And I do this technique once again as a reminder to some of the steps. You bury the adapter of the 6.0 tube. I personally do not use cuff tubes. It makes it easier. If you have to intubate smaller patients, they do make smaller stylets. This is an 11 French Cook that will fit through a smaller tube. And then if you have to do it to a kid, you can go through a 2 or a 1.5 LMA with this size tube, with this size stylet, and this will also fit through a 4.5 or a 4 very easily. The technique's the same, the equipment is different. And that is how you intubate a patient through an LMA in place. All right, let's see.